Hello, everybody. My name's Ed Pavlik, and I'm in Lexington, Kentucky, and I'm with my colleague in the United Kingdom.
Frank Lawton in London.
Great. It's good to see you, Frank. It's a real, I understand your weather's getting a little cool there, but
It,
it's
it's getting cool, yes. The nights are becoming frosty and it's getting dark quicker, but it's actually quite pleasant. I like the seasons. I look forward to all of them, and then I look forward to them, some of them disappearing. I don't like January because it's after Christmas, it's cold and miserable. But in February, when the daffodils and the snowdrops are beginning to come up, I feel rejuvenated. I feel it's spring again. January's not my best month, so we've still got a couple of months to go.
well, very good. Well, today we're going to consider a question in Gynec Garage, which is ovarian cancer survival affected by menopausal hormone therapy that's given before and after or after diagnosis? This paper comes from the International Journal of Cancer that considers this question. It's called Use of Menopausal Hormonal Therapy Before and After Diagnosis and Ovarian Cancer Survival, a Prospective Cohort Study in Australia. This work is important because it illuminates factors that may have roles in risk and survival. Again, I'm going to have some perspectives from both human and artificial intelligence. Well, if we look at this paper, uh, what we can see very quickly, uh, if I could be as quick as I say quickly, um, is that the paper looks at this problem from two aspects. One, the high use of menopausal therapy are basically those people who are postmenopausal. And if you can see in this particular graph, um, what we can conclude is in this group, which has been using prior to diagnosis of ovarian cancer hormonal therapy, that that there is a uh, improved survival in the group that has ovarian cancer. And if we separate the serous ovarian cancers, the high-grade serous, from other ovarian cancers, what we see is that serous ovarian cancers are more likely to, in the data from this study in Australia, are more likely to have a benefit spelled out by uh, the risk factor. Um, and and basically in purple we have the non-ovarian cancers, non-epithelial ovarian cancers, non-high grade serous, and in red we have the high grade serous ovarian cancers. So the other thing that comes out of this paper is that if we look at younger women under age 55, and because the group is going to be small of using it before diagnosis, if we look at them at use of hormone therapy after diagnosis, there's no difference in a benefit on survival. And one of the reasons that that's the case is the numbers become very, very small that are being considered here. So you can't get a statistical difference, even though it appears here that these numbers are offset by these numbers. So the conclusion of this paper really is that it's fine to consider hormone therapy for women who've got a diagnosis of ovarian cancer, and that's basically based upon this figure right here. So when we look at the same problem being analyzed by AI, one of the things we can say is that the Gemini AI has said that that longer durations of pre-diagnosis hormonal therapy may be associated with greater survival benefits. Uh, Unfortunately, it's not in agreement with the paper. The paper said that associations did not differ by recency or duration of use, which is different from what a Gemini said. Likewise, when we look at, so that's one entirely wrong conclusion. And then Copilot applied their logic to the 26% improvement in ovarian cancer specific survival, but they didn't realize that it only applied to postmenopausal women. So in the end, what can we say? Well, one thing we can say is that language really differed between what Copilot basically said in its narrative and what was said in the paper. And the language was in the paper could be considered and versus in Copilot, what it was said, there should be caution applied. So in terms of wording, I think that's significant. But the most important thing is reading the paper, you would know that the survival advantage that was gained for high-grade serous carcinoma by hormone replacement therapy was only 3.7 months over a 5-year period. That fact that you would get as a human reader or reviewer was not captured by either Gemini or by Copilot. So in the end, yeah, you can find these differences and you can find them with significance, and you can find them where you may be really sort of saying, geez, the group is pretty small. But really, under those conditions, what do they apply to? And they apply to a marginal over 5-year period survival advantage. And that's the end of it. Frank, what do you think?
Yes, I think that's a very good point. And I mean, essentially, I don't think that the data suggests that giving hormone replacement therapy to women who've had ovarian cancer is beneficial. They don't do worse. They live a little bit longer. I think something that's important, though, of course, is that does this apply to, I mean, obviously the high-grade carcinomas seem to do much better. Does it apply to the other ones? And whether or not mucinous or clear cell carcinoma or carcinomas that may have arisen within an endometriotic lesion, should they be subject to HRT? And clearly the numbers in this study are not good enough. So I think if you were a clinician and a woman who's had ovarian cancer comes to your surgery and asks about HRT, I think it is probably beneficial. It might be less beneficial in women with certain histologies. But the other thing to remember, of course, is that it prevents osteoporosis. And I had a look at some figures which are actually quite stunning. In 2020, 1 in 2 women over the age of 50 were in the US were at risk of osteoporosis. There are 6,390 deaths from ovarian cancer in the UK in a year. And there are 138,000 osteoporosis-associated deaths, usually bone fractures and the sequelae thereof. The USA, 21,000 odd ovarian cancer cases and 221,000 osteoporosis cases. So HRT probably is helpful in prolonging survival, albeit fairly small, in ovarian cancer, but it prevents you from getting osteoporosis, and you're more likely to die of osteoporosis, big studies like that, than you are of ovarian cancer. So I think it's something that is a good study. It shows it is beneficial, and it obviously should be something that people consider. I don't think you should say to women, oh no, you've had ovarian cancer, you can't go on HRT. That's just not true.
I think that's the most important thing here that, sort of comes out of the paper, despite the fact that the numbers are small.
Yeah, absolutely.
Well, we've done it again, Frank. We've survived each other and survived the papers. And so we can look forward.
We're getting good at this.
Yeah, we can look forward to doing it again next month.
Indeed, we shall. Okay. I'll see you then.
Okay, Frank.